Okay, I will now introduce yes, Katarina from the MGH. Who is she? Where is she? Okay, and she, you know, the team of from the MGH from K Haerter have evaluated migraine in mouse models, and I think she will present some results and other additional news from this field.
Thank you very much, Dr. Chabria, for this very nice introduction. And thank you very much for giving me the opportunity to present about the association between migraine, CADASIL, and small artery diseases of the brain. I will try to discuss possible mechanisms that might underlie the association of migraine and vasculopathies. First, I will provide some evidence, some clinical evidence for the association between migraine and vasculopathies and provide insights from animal experiments and human studies. Then I will introduce you to a cerebral phenomenon, the so-called spreading depolarization, which is thought to underlie migraine and actually may be the link between migraine and vasculopathies. Let's start with some clinical evidence for the association between migraine and vasculopathies. Let's start with the acquired vasculopathies. I only will comment on the acquired vasculopathies briefly because I have been asked to present and to focus mostly on small artery diseases of the brain. So just this slide about the acquired vasculopathies that are associated with migraine. Migraine is an established and independent risk factor for ischemic stroke. It increases the stroke risk by around twofold, with a remarkable increase in young females who are on oral contraception and smoking. Here it increases the stroke risk up to 9-fold. Migraine also increases the risk of ischemic heart disease roughly twofold, and particularly in those migraineurs with atherosclerotic lesions, which is in contrast to migraine increasing the risk for ischemic stroke, which is particularly increased in migraineurs without cardiovascular risk factors, suggesting that the mechanism for migraine increasing the risk for stroke and ischemic heart disease is a different one. Migraine also is associated with arterial dissections and vascular anomalies such as AV malformation or small angiomas and the reversible cerebral vasoconstriction syndromes. This is a group of diseases characterized by multifocal vasoconstrictions in the brain that can last days or weeks. And typical symptom is the sudden onset thunderclap headache, but migraines can also occur. These are genetic vasculopathies that are associated with migraine. We have the retinal vasculopathy with cerebral leukodystrophy, the RVCL syndrome, then the hereditary infantile hemiparesis, retinal tortuosity, and leukoencephalopathy, the Hirardel syndrome that we already learned a little bit about from Dr. Kalimo. And we know that migraine is 2- to 5-fold increased in patients with CADASIL. Now let's start with the RVCL syndrome. RVCL is caused by mutations in the TRUX1 gene, which encodes a 3,5 exonuclease, as we already heard this morning. This 3,5 exonuclease shows an altered subcellular localization and causes accumulation of DNA intermediates that could trigger an abnormal autoimmune response, which I will outline in the following slides a little bit more. 70% of the RVCL patients have migraine, and interestingly, in the RVCL syndrome, migraine without aura is more common than migraine with aura, which is in contrast to the other vasculopathies that are associated with migraine. There, migraine with aura is more common. Other neurological manifestations are cognitive and psychiatric disturbances, such as personality disorders or aggressiveness, infarcts, and focal syndromes. Later on, neuroradiology findings typically occur, such as contrast-enhancing cerebral mass lesions, calcifications, or leukodystrophy. Pathology findings are complex, multi-layered capillary basement membrane disturbances, in the small cerebral vessels, an obliterative vasculopathy with necrosis and astrogliosis. What we now call RVCL has been initially described in 3 families and named with 3 different disease names: the HVR, CRV, and HERNS. HVR stands for hereditary vascular retinopathy and mostly affects the retina and the CNS. In the retina, changes resemble those of a hypertonic or diabetic retinopathy, and cerebral changes resemble those of a delayed post-radiation vasculopathy. Patients also suffer from the Raynaud syndrome, which is a disturbed vasomotor reaction of distal digital arteries upon exposure to cold temperature. The fingers turn white, are extremely painful, and feel numb. Additional features of the HVR syndrome are neuropsychiatric symptoms, stroke-like episodes, pseudotumor, and subcortical MRI lesions. The other 2 diseases, CRV and HERNS, are summarized on this slide. Dr. Grant described the cerebral retinal vasculopathy in 1988 and found that this disease typically starts at the age of around 40 and has a 100% mortality within 5 to 10 years. Dr. Jen then, in 1997, described a Chinese-American family with hereditary endotheliopathy with retinopathy, nephropathy, and stroke. He was able to observe this family over 3 generations. Later on, it has been discovered that all 3 diseases can be mapped to the very same disease locus on chromosome 3, which encodes the TREX1 protein. Here you can see the TREX1 protein in a normal person, which has a perinuclear localization. And upon sublethal DNA damage, TREX1 translocates to the nucleus and together with PARP repairs and edits DNA changes. So TREX1 protein is a 3,5 exonuclease that is involved in removing cytosolic DNA. The RVCL mutated TREX1 protein shows an altered localization, as you can see here. While still having a normal exonuclease activity, we say that there is a toxic gain of function with an accumulation of DNA intermediates in the cell, leading to an abnormal autoimmune reaction. The next genetic vasculopathy associated with migraine is HEREDL, which stands for hereditary infantile hemiparesis, retinal tortuosity, and leukoencephalopathy. HEREDL, as we already learned, is caused by mutations in the COL4A1 gene, which encodes the alpha chain of type 4 collagen and leads to a disruption of vascular integrity. Underlying pathological findings are complex basement membrane abnormalities in skin, kidney, and cerebral vasculature. In this vasculopathy, migraine with aura is more common, but also 1 patient has been described with migraine without aura. Other neurological manifestations are seizures, infantile hemiparesis, lacunar infarcts, and also porencephaly, which probably is due to the high incidence of intracerebral hemorrhages. And now we get to CADASIL. Probably due to the small sample size number in HEREDL and RVCL, not much known is about the migraine phenotype in these first 2 vasculopathies, but we have a little bit more information about the migraine phenotype in CADASIL. We know that CADASIL, as the first symptom, manifests with migraine with aura. The prevalence of migraine in CADASIL patients is 38%, which is 2 to 5-fold increase compared to the general population. In European studies, the incidence is 14 to 72% versus only 5% in Asian studies, which coincides with general epidemiological data. 80 to 90% of the migraineurs in CADASIL have a migraine with aura. 44% have a typical aura. With aura, I mean focal neurological symptoms that precede the headache phase. And 56% also have atypical aura, which could be a prolonged aura, hemiplegic aura, or an aphasia. We also found a gender difference. between male and female CADASIL patients with respect to the migraine phenotype. In female CADASIL patients, there is evidence for an earlier onset, and migraine is more prevalent in females compared to male CADASIL patients before menopause. Moreover, visual and aphasic aura are more common in female CADASIL patients compared to males. When we look at the disease course of CADASIL, we can see that 14% of the CADASIL patients with migraine have an increase in attack frequency before the first ischemic event, whereas after the first stroke, most of the patients, 54%, reported decrease or a cease of migraine attacks. Interestingly, the MRI findings between CADASIL patients with or without migraine are not different. Now, what is the mechanism linking migraine with acquired or genetic vasculopathies? One possibility is a spurious association, which could be due to the high incidence of migraine in contrast to the very low incidence of the genetic vasculopathies. Alternatively, shared genetic factors could be the link between migraine and vasculopathies. For example, polymorphisms in the CADASIL-causing Notch3 gene have been shown to slightly increase the risk for migraine, which the same is true also for the RVCL disease locus. Alternatively, vascular endothelial dysfunction could be the mechanism because polymorphisms in genes that are responsible for a proper endothelial function have been associated with migraine. Another possibility is neuronal mechanisms as a link between migraine and vasculopathies via the phenomenon of cortical spreading depolarization. Now, what is spreading depolarization and why do we think spreading depolarization is important for the migraine? These crosses stand for neurons, and at a normal transmembrane ionic equilibrium, we have high potassium levels in the neurons and low potassium levels in the extracellular space, thanks to the sodium-potassium ATPase. The opposite is true for sodium. Sodium is at much higher levels extracellularly compared to intracellularly. And the same goes for calcium. Levels are much higher in the extracellular space compared to the intracellular space. What now happens during spreading depression is that upon depolarization of a minimum volume of brain tissue, the membrane ionic gradient goes down and potassium exits the cell, while at the same time, sodium enters the cell and pulls water into the cell such that the cells swell and the extracellular space shrinks. Moreover, calcium enters the cell, which triggers the release of glutamate, which then exits the cell and facilitates the spread of spreading depolarization by depolarizing adjacent neurons. What are trigger factors for spreading depolarization? We have a couple of excitatory trigger factors that are KCl, sodium-potassium inhibitors, excitatory amino acids, electrical stimulation, or more recently, optogenetic methods. With relevance to vasculopathies and the potentially increased risk of spreading depolarization, there are also a couple of vascular trigger factors that are related to ischemia that can trigger spreading depolarization. For example, microemboli or the vasoconstrictive substance endothelin-1. Spreading depolarization typically has a centrifugal spread pattern and can be recorded with glass capillary microelectrodes inserted into the cortex. This is a typical spreading depolarization that can be recorded with such glass capillary microelectrodes upon topical application of potassium chloride, for example. In parallel to this DC shift, we see first a burst and then a suppression of neuronal activity in the EEG and a reduction of cerebral blood flow at the same time. Cerebral blood flow actually remains reduced for more than an hour after spreading depolarization. Why do we think that spreading depolarization is the electrophysiologic event underlying migraine. There are several lines of evidence suggesting that. One is a congruence between the electrophysiological features of SD and aura symptoms. Already in 1941, before spreading depolarization has been described, Lashley found, when he had a close look at his own visual aura, that the visual aura symptoms spread at a rate of 3 millimeters per minute, the similar spread that spreading depolarization has when he looked at the retinotopic organization of the visual cortex. Moreover, he observed that at the wavefront of his visual aura symptoms, there are fortifications, those zigzag lines, which are positive symptoms and could be due to the initial short neuronal excitation that is followed by the longer lasting suppression of neuronal activity, as you can see here in the scotoma. The next evidence comes from a congruence between cerebrovascular changes during aura and during spreading depolarization. For sure, the strongest piece of evidence comes from high field strength MRI performed by Dr. Hajikani and Dr. Moskowitz when they put a migraine patient during his visual aura into the MRI. This is a drawing of the visual aura perception, and what Hajikani found is that first occurred a small increase in the Bolt signal and then a reduction. And this change in the Bolt signal propagated at the same rate like spreading depolarization and in retinotopic congruence with the visual aura perception. The next evidence comes from the fact that spreading depolarization is able to activate nociceptive pathways involved in headache pathogenesis. Dr. Moskowitz showed that spreading depolarization is able to induce CFOS upregulation in the spinal trigeminal nucleus caudalis. And very recently, Dr. Burstein groups showed that spreading depolarization is able to activate meningeal nociceptors and also trigeminal-vascular nerves in the trigeminal spinal nucleus caudalis. Interestingly, there was a 30-minute latency between the spreading depression and activation of the nociceptors, which is similar to the latency that we observe after aura onset and the headache onset. The next piece of evidence is that factors that modulate spreading depolarization also modulate migraine in the same direction. We found that mutations that are known to cause migraine in humans also enhance susceptibility to spreading depolarization in genetic mouse models, in the case of familial hemiplegic migraine. As all of you know, migraine is 3 times more common in females compared to males. And when we looked at our mice, we also found that susceptibility to spreading depolarization is higher in female mice compared to males, which is due to a higher level of female gonadal hormones and lower level of male gonadal hormones, which we found to inhibit spreading depolarization. Another factor that inhibits migraine and at the same time spreading depolarization are migraine prophylactic drugs. Despite belonging to different pharmacological classes, migraine prophylactic drugs are able to inhibit spreading depolarization after a treatment duration of at least 4 weeks, which again correlates with a clinical observation that migraine prophylactic drugs need at least a 4-week treatment duration before they help the migraineurs. Last but not least, there are shared trigger factors for spreading depolarization and migraine attacks, such as ischemia. We know that the odds ratio for migraine in patients with a patent foramen ovale and a large right to left shunt that enables the passage of microemboli into the cerebral vasculature is almost 8-fold. When we look at the prevalence of migraine with aura among patients with or without patent foramen ovale, we see that the incidence of migraine, the prevalence of migraine with aura is much higher in those with a patent foramen ovale compared to those without. And the other way around, Looking at the prevalence of the patent foramen ovale, we see that the prevalence is higher in migraineurs with aura compared to those without. There are further experiments that have been done and that show that actually migraine aura can be triggered by PFO testing using a bubble test or the Valsalva maneuver that would cause small occlusions of the arteries and would trigger a migraine aura. Here's the evidence from animal experiments that microemboli in fact can trigger spreading depolarization. Dr. Nozari from our lab showed this by introducing small emboli into the internal carotid artery that then led to small arterial occlusions and produced spreading depolarizations. He showed this for air microspheres in different sizes, cholesterol, and fibrin. Some animals developed severe tissue defects, actually only a subset of those animals, as you can see here. Some animals developed lacunar lesions, as you can see here, whereas most of the animals didn't develop any lesions, but only developed a spreading depression upon infusion with microemboli. When we look at the clinical cause of CADASIL, there are also some migraine characteristics in the phenotype that would suggest spreading depolarization as the link between migraine and CADASIL. For example, 80 to 90% of the migraineurs with CADASIL have a migraine with aura. Or the migraine phenotype is more severe in female CADASIL patients than in male CADASIL patients. Remember, we found a more severe spreading depolarization phenotype in female mice compared to male mice. And also, the clinical course of CADASIL supports a strong role for spreading depolarization and mediating migraine in CADASIL patients, as I will outline in more detail now. At early disease stages, as we saw a couple of slides before, the migraine incidence is 2 to 5-fold increased, which could be due, if we believe our animal experiments, to an enhanced parenchymal susceptibility to spreading depolarization that are potentially triggered by transient ischemic events. Here's the evidence from our animals. Upon topical application of KCl on the cortex, we found that the number of spreading depolarizations triggered by KCl was higher in TGR90C CADASIL mice compared to Y-type mice, which was similar to the spreading depolarization phenotype in mice, transgenic mice with a human migraine syndrome familial hemiplegic migraine. We also found a higher number of spreading depolarizations upon KCl compared to Y-type animals. When we changed the trigger for spreading depolarization from KCl to a vascular one, like upon arterial occlusion, we found that the ischemic depolarizations triggered by the arterial occlusion were also more frequent in CADASIL mutant mice compared to Y-type mice. Moreover, the cumulative ischemic depolarization duration was longer compared to Y-type mice. We observed the same again in our mutant mice for the migraine syndrome familial hemiplegic migraine. Here you see the cumulative number of spreading depolarizations after arterial occlusion in the mutant mice is more than 2-fold higher compared to the number in Y-type mice. As a result, we found that the tissue defects after a standardized arterial occlusion were much larger in CADASIL mutant mice, shown with the red bars, compared to Y-type animals, shown with the green bars. This was true for young animals, aged animals, and male and female animals. We observed a similar phenotype again in our transgenic mice for the migraine syndrome familial hemiplegic migraine, with larger infarct areas in mutant mice compared to Y-type animals. Now, what happens during late disease stages when the migraine incidence is reduced? We had a look at aged Notch3 knockout mice, and we found even though the susceptibility to spreading depolarization and the number of spreading depolarizations upon a standardized amount of KCl was still higher compared to the Y-type animals, it was significantly lower compared to young animals. So we could reproduce the reduced migraine frequency, we could link it to a reduced SD susceptibility in aged Notch3 knockout mice. We didn't yet test the other CADASIL models. Why do we observe this reduced susceptibility to spreading depolarization? There is evidence in CADASIL, as we already learned, for cerebral hypoperfusion and for astrogliosis. So what we tried in our lab is to model the cerebral hypoperfusion. We used the model for mild chronic cerebral hypoperfusion by putting steel coils around the common carotid arteries on both sides. This procedure would reduce the diameter of the common carotid arteries by 10% and would reduce the cerebral blood flow by 20%. And after 4 weeks, we tested susceptibility to spreading depolarization. And what we found was that chronic cerebral hypoperfusion in this carotid stenosis model indeed reduced susceptibility to spreading depolarization. Here you see a sham animal, normal wild-type animal, and here you see 2 animals after stenosis of both common carotid arteries, and we see that the number of spreading depolarizations is like half of that compared to the normal animal with normal cerebral perfusion. What could be the factors that would bring down SD susceptibility after cerebral hypoperfusion? One possibility could be a neuronal loss, another possibility could be astrogliosis, which has been described in CADASIL. We looked at the brains of those mice with chronic cerebral hypoperfusion, and indeed we found an upregulation. Could you please turn down the light a little bit? We found an upregulation of the reactive astrogliosis marker GFAP in mice with chronic cerebral hypoperfusion, suggesting that the higher number of astrocytes would buffer extracellular excitatory substances such as KCl, and by this reduce susceptibility to spreading depolarization. We conclude that spreading depolarization may link migraine and vasculopathies. A microembolic occlusion of a small cerebral artery that would remain clinically insignificant in healthy persons could trigger spreading depolarization or migraine in a susceptible brain, or even worse, stroke, if vascular reactivity, the vascular response to a microembolus, would be altered, as it could be the case in vasculopathies. Thank you for your attention.